Good morning everyone. UN Mehta Institute of Cardiology and Research Center is organizing weekly academic session for continuous cardiac education. Today's topic of discussion is nomenclature and classification of congenital heart diseases, which would be taken up by Dr. RITESH SHAH sir, who is professor in Department of Cardiac Anesthesia at UNMICRC. He has a 22 years of teaching experience.
Hello, good morning. Welcome to Continuous Cardiac Education program from UN Mehta Institute of Cardiology and Research Center. Today we'll discuss nomenclature and classification of congenital heart disease. So many terms used to describe same disease in different parts of the world that causes confusion. So to avoid the confusion, some system must develop which will be universally accepted. Nomenclature must allow all congenital heart defects to be described unambiguously, accurately and succinctly. It must assist the clinical cardiologist to diagnose and describe all those anomalies during life, and it must be compatible with the morphological findings so that it is valid for examinations at operations or necropsy as it is during diagnostic investigations. A classification and nomenclature should not be difficult to learn or to remember, and clarity is the touchstone of the success. So what is nomenclature? Nomenclature is a system of names used in a branch of learning or activity. It may be in the society, in a tribe, particular tribe or particular disease. And classification is an arrangement according to some systemic division into classes or groups based on some common factor to each. So, in order to properly describe and classify any heart, it requires to see for relations of structure of heart and manner how they are joined together is called segmental approach. Segmental approach initially described by Van Prague and associates from Boston University, US. Then it is modified by Anderson from Europe, and then it is combined as a sequential segmental approach. We'll discuss one by one. So first comes what is means of right and left in heart. Usually in body, with whatever structures that are right on the body is called right structure, and what is left in the of the body is called left structure. In heart, particularly when we consider the morphology of the heart, right atrium, right ventricle or right AV valve, that are considered right when they are morphologically right, whether it is situated on the left or right. So there are peculiar features of the right atrium. If it is in the left sided atrium, it is called right atrium. Same thing applies to the ventricle as well as AV valve. So identification of sidedness in cardiac chamber is often reliant upon multiple observations, and every rule for identification of particular chamber or junction is has its own exception. But fortunately, there are most rules applies most of the time. So Van Prague has given a 3-segment model for classification of heart disease. Van Prague notation imposes on its users a systemic approach to anatomic description. It is helpful for the interpretation of imaging studies as well as reporting of the results. Van Prague notation is a 3-part series of letters or letter groups, with each part corresponding to a key segment or embryonic region of the cardiac anatomy, that is atria, ventricles and great arteries. It is conveyed by 3-letter notation in braces. For example, SDS. The first letter in the series conveys information about the atrial situs. The second letter conveys information about whether ventricle is looped to right or left, and the third letter is position of the and relation of the great vessels to each other. So we discuss one by one. In visceroatrial situs, in this image you can see In situs solitus, liver is on the right and stomach and spleen is on the left side. Lung is trilobed on the right side, while left side it is bilobed. And bronchial anatomy is peculiar of the situs solitus. While in situs inversus, it is usually inverted. Liver is on the left, while spleen and stomach is on the right side. Right lung is bilobed, while left lung is trilobed. And bronchial anatomy changes in opposite direction. In situs ambiguous, there may be a anatomy, there is no fixed anatomy. It is also known as heterotaxis syndrome, where there may be an anatomy of bilateral right-sided morphology or bilateral left-sided morphology, or it is indeterminate. You can see atrial arrangement in situs solitus, that is usual arrangement. In situs inversus, that is mirror image atria. In situs as well as in situs ambiguous, that is right isomerism or left-sided isomerism. In developing heart tube, parts of the tube from cranial to caudal are truncus arteriosus, bulbus cordis, ventricle, atria, and great sinuses, sinus venosus. When tube elongates and folds caudally and ventrally in a limited space, it normally curves towards the right, so that part of bulbus cordis comes right, that becomes future right ventricle, and part of ventricle becomes left, that becomes future left ventricle. This is called delope of normally related ventricles. When this tube, instead of curving towards right, it curves towards left, that is called L loop, where bulbus cordis, that is future right ventricle, becomes left sided structure, and future left ventricle becomes right sided structure. Sometimes in crisscross heart, or when one ventricular is superior to other, there may be, you cannot determine exact looping of the ventricles, where hand rule is important. What is hand rule? So when you put your palmar surface of hand over the ventricular septum, and your thumb is in the inlet of the ventricle and fingers in the outlet of the ventricle, if you accommodate your right hand, it is usually D loop. When you accommodate your left hand, it is called L loop of the ventricle. It is particularly important for a cardiac surgeon as well as morphologist. After looping of the ventricle comes the relationship of great arteries. Usually aorta and pulmonary artery are classified according to their position and relation at the level of the aortic and pulmonary valve. In normal anatomy, aorta is right and posterior to pulmonary artery. In inversus, aorta is usually left and posterior, while in DTGA it is right and anterior, while in LTGA it is usually left and anterior to pulmonary artery. Van Praag segmental classification do not give information regarding the AV valve and ventriculo-arterial relations, whether it is concordant or discordant, and whether any associated malformations of the chamber, septa, outflow tract or great vessels are present or not. Later on they modified it and added information regarding other anatomical abnormalities. Now Anderson and colleagues have given above this segmental anatomy. They describe the connection between atria and ventricle as well as ventricle and great arteries, and how they are related to each other in their segmental classification. It documents the anatomy of cardiac components as well as connections between them, atrial arrangement, whether it is normal, inverted or isomerism, atrioventricular connections, whether it is concordant or discordant, whether it is bilateral connection to one ventricle like in DILV or DRV, whether it is mixed, absence of right or left AV valve. These are all considered in the Anderson's approach. Ventriculo-arterial connections, whether it is concordant, discordant, DORV, DOLV, single solitary trunk with either pulmonary or aortic atresia, or single outlet solitary arterial trunk like in truncus arteriosus. They all included in Anderson's approach. So main thing in Anderson's approach is how arrangement and topology of cardiac chambers and how they are connected or not connected and mode of connection when they are connected. Now after considering all these, usually the both Anderson and Van Praagh are combining sequential segmental approach, where first you consider the thoracoabdominal situs, whether it is situs solitus or inversus or ambiguous, then followed by position of the heart in the sternum, in the thorax, whether it is levocardia, mesocardia or dextrocardia, then followed by segmental analysis. First atrial situs, whether it is situs solitus, inversus or ambiguous, followed by ventricular looping, either D loop or L loop, followed by connections of atrioventricular valve and then connections of ventricular arterial junctions. Then comes infundibular morphology, whether it is subpulmonary or subaortic, or there is a bilateral infundibulum, or there is an absence of infundibulum. Then comes the relationship between semilunar valves, with whether it is situs solitus or inversus or D malpose or L malpose or anteroposterior connections, followed by any other associated major or minor abnormality. These are the steps to identify proper structure, and we are looking one by one all these. We can diagnose exact situs of the patient with the help of X-ray and echography, or sometimes it requires to do CT scan or cardiac MRI for diagnosis of thoracoabdominal situs. First, we have to establish visceral situs by determining whether the liver, stomach and spleen are located on the patient's right or left. The structure of bronchopulmonary anatomy can be useful for identifying morphology of right atrium, because pulmonary silentness usually reflects atrial silentness. So if right bronchus is on the right, usually right atria is right-sided atria is right atrium. Right bronchus is eparterial, that is early because of its early takeoff. Pulmonary artery is below the right bronchus, and its right lung is trilobe, while left bronchus is hyparterial. As it take off distally, pulmonary artery is superior to the left bronchus. So right bronchus is hyparterial. It takes take off distally. Left bronchial artery is usually above the left bronchus, and left lung is usually bilobed. Now comes the position of the heart in the chest. Position of mass of the heart with respect to sternum is described by using prefix levo, dextro or meso. Just it should be borne in mind that descriptors of cardiac location within the thorax do not imply a particular internal structural abnormality of the heart in relation to thoracoabdominal organs. You can see in this image that in levocardia, cardiac mass is left side of the thorax. In dextrocardia, cardiac mass is in the right side of the thorax, and in mesocardia it is situated in the midline. Usually morphology of atria is diagnosed by 2D echo by tracing the supradiaphragmatic inferior vena cava in usually subcostal view. In doubtful cases, when bronchial anatomy is helpful, as it is usually consistent with atrial morphology as we have discussed. Now, how to identify atria morphological characteristic of right and left atria? Usually, right-sided appendage is trapezoidal with a broad connection at the base of the right atria. It contains pectinate muscles that extends from the appendage towards the AV valve. Septal surface has a superior and inferior limbic bands. Myocardial components include crista terminalis and tinea sagittalis, and it usually receives flow from the coronary sinus as well as supradiaphragmatic IVC. All these features may not be consistent, but shape of the appendage and pectinate muscles are diagnostic of morphologic right atrium. In left atria, appendage is usually tubular with a narrow connection to the chamber. Pectinate muscles are confined within the tubular appendage. Septal surface is usually smooth and have flap valve for foramen ovale. You can see in this image smooth surface in left atrium, while right atrium has pectinate muscles that goes from appendage up to the crux of the heart, that is AV canal. Now comes ventricle. Moderator band is the diagnostic of right ventricle. It extends from the septum to the anterior papillary muscle. There are no such band in left ventricle that attaches to the septal surface of left ventricle, which is usually smooth. In right ventricle, there is a coarse trabeculae, while in left ventricle, it is a thin and fine trabeculae. Papillary muscles attach to both the free wall and interventricular septum in case of right ventricle, while in left ventricle, papillary muscles attach to the free wall only. It is usually not attached to the septum. Right ventricle has tricuspid AV valve, while left ventricle has bicuspid aortic valve. Septal and parietal bands are there in the right ventricle, while left ventricle has smooth superior septal surface. You can see in this image coarse trabecula in right ventricle, while left ventricle has fine trabecula. There are no intrinsic features which enable to distinguish aorta from pulmonary artery, but branching pattern is important. Usually aorta gives rise to at least one coronary and multiple systemic arteries, while pulmonary trunk bifurcates after its origin. There may be solitary. Confusion arises when there is a common arterial trunk or then there is a solitary arterial trunk, where you can identify pulmonary artery from their branching pattern. Now comes classification of congenital heart disease. Initially it is classified according to it is either patient is cyanotic or acyanotic. Acyanotic disease are ventricular septal defect, atrial septal defect, PDA, coarctation of aorta, congenital aortic stenosis, AVSD, etc. While cyanotic are tetralogy of Fallot, pulmonary stenosis, transposition of great artery, pulmonary atresia, etc. But this is confusing as tetralogy of Fallot may not be cyanotic. There may be a pink tetralogy which is not cyanotic, while in patient of VSD may become cyanotic after Eisen migration, or there may be a AV septal defect which is may be cyanotic. So this is slightly confusing, so they have classified it another way. In 2000, the International Nomenclature Committee for Pediatric and Congenital Heart Disease was established. This committee eventually evolved into International Society for Nomenclature of Pediatric and Congenital Heart Diseases. In 11th iteration of ICD discusses a classification tree that will permit the widespread use of a single diagnostic list for congenital heart disease, both for administrative and clinical purposes. Until ICD 11 iteration, congenital cardiac diseases remain very poorly presented. Outdated terminology, inconsistent logic, and little appreciation of the inherent complexity of lesions are there. Initially, there were two groups of International Pediatric and Congenital Cardiac Code, where there were one European and one American, with number of list of cardiac diseases included with different names. International Nomenclature Society then combines whole list of uniformity and standardize it for gathering and retaining accurate and detailed clinical information, free from duplication of data entry, enabling comparative studies across units and across nations. That is called International Pediatric and Congenital Cardiac Code. They have divided code into different levels: segmental system classification, like first in level 1 there is a mainly focus on great veins, atria, atrioventricular junction, ventricles, ventricular arterial junctions and great arteries. In level 2 they go deeply into each part in great veins, whether it is systemic veins and pulmonary veins, followed by in atria, right atrium, atrium septum and left atrium. They go even deeper in level 3, where you can see in systemic veins it is systemic venous anomaly of superior vena cava or inferior vena cava. In pulmonary veins, whether there is a total anomalous pulmonary artery connection or partial anomalous connection or coat atrium. Likewise, they modified it into level 4, where they goes much more deeper than this, and every disease has been given a particular code for each level, and that is uniform, and you can compare it the data of different institutes to know how they are doing particular reporting as well as surgical corrections of these diseases. So after that, IPCCC usually all diseases of congenital heart pediatric patients are uniformly stated in a single code, and that will helpful in the treatment of part of that patient.